We're going to get through this and we're going to talk about bacterial STIs. So this is a really big topic, so I'm going to just make sure we know what we're going through so that at least you know what the plan is. All right, so we're going to end up talking about gonorrhea, syphilis, chlamydia, and last but not least, bacterial vaginosis and trichomoniasis. Okay, so there's 5 of them. Let me say it one more time. Gonorrhea, syphilis, chlamydia, bacterial vaginosis, and trichomoniasis. All right, so we can get through this, I promise, and we're gonna survive. Before we start, I wanna remind you that the reportable ones are all within a week, bacterial, all within a week, and except for syphilis, the primary and the secondary stage of syphilis is 1 work day. Syphilis, remember the primary and secondary stage is 1 work day. All right, so all of these are within a week. We're talking about our chlamydia, our syphilis, and our gonorrhea. Okay, so we're gonna remember these are the main ones, and that's why I'm gonna start with these reportable ones, the ones that the healthcare reporters have to report before, report when they see a patient with this within a certain amount of time frame. All right, so what are we gonna be looking for? I always like to do this systematically. And I like to start with what are the causes of gonorrhea. Now, they're all gonna have the same causes because they're STIs, but they differ slightly and they have all their unique bacterial things. So, you know, we can't see bacteria with our eyes, and I get that, but these little critters are interesting. Okay. So let me talk to you about Neisseria gonorrhea. Neisseria gonorrhea is going to look very interesting on the gram stain. So they're a gram-negative diplococcus. Remember to say gram-negative diplococcus? Think your 2 little eyes, gram-negative diplococcus. So you're going to see gram-negative diplococcus if you find this. So how long does it take to incubate? It takes about 3 to 8 days. And remember, 3 to 8 days to incubate for this gonorrhea. So very quickly you're going to see effects if they have symptoms, and the patient does not develop an immunity against gonorrhea. Very scary. So think about these things. The transmission is direct physical contact with infected hosts, the vaginal, anal, or oral sex. So you think you're doing oral sex? You're not excused. So yeah, it could be all of them: anal, vaginal, and oral sex. All right, so now that we know once you get this, you're not immune to it, you're still going to be reinfected over and over and over again. All right, just mind that. Now let's talk about our clinical manifestations, and then we can figure out how to diagnose. So we're gonna do things in order. So we know our causes are gram-negative diplococcus, and that they're only 3 to 8 days of incubation, no immunity, and their transmission through an STI, so it's one of your STIs. All right, so our clinical manifestations may differ between women and men. You may see different things. All right, that's bothering me. All right, so women, you're gonna see dysuria, so painful urination, asymptomatic or often overlooked symptoms. So if it may not even be seen, you may not even see any symptoms at all, which is super scary because there's complications associated with all of these. And if you don't see symptoms, you're not even gonna know you have it. So then you're just spreading the whole thing, and it's like, whatever, okay, you get the point. So asymptomatic dysuria. If it's noted, there may be redness and swelling at the site of contact, usually the cervix or urethra. So the teacher was saying a strawberry cervix. So redness and swelling at the site of contact. So it depends. Where was the contact? Was it the urethra? Was it the cervix? Was it both? It could be everything. I don't know. So that's the main thing to watch for. You're going to see green and yellow exudate. Green and yellow purulent discharge. So remember G for green, gonorrhea for green, and yellow exudate. So it's gonna have this green-yellow color. So that's pretty easy to remember. So G for green, because I remember chlamydia was C for clear. So it's purulent. The men are going to have urethritis, so pain at urination. Why? Because they have inflammation. So they're also going to have dysuria. So they both have dysuria, urethritis, that inflammation. Sometimes there's no symptoms also, so both sexes, they could be no symptoms. So they're passing this down. There's profuse purulent drainage. They have painful swollen testes, and remember, when you see this discharge, the specific characteristics you're going to be looking for is that green to yellow discharge, or exudate discharge from the penis, wherever you want to call it, or the vagina, wherever you see it, if you're man or woman, it depends. So those are the green and yellow exudates from the genitals. Just remember that. Okay. And we know what it's caused. It's caused from the Diplococcus, 3 to 8, incubate, and no immunity, and you know how you get it, so have protected sex. All right, so how are you going to diagnose it? So the physician is going to, or the nurse is actually going to check their history of contact to be an STI, you have to check their sexual contact history, especially if their partner's infected. They want to make sure who they were having sex with. All right, so the gold standard is a cultural gram-negative stain, which makes it really easy, and that's why I say it's important to know that the Diplococcus, because you're looking on the gram stain, you're looking for a specific looking feature. If the Diplococcus, it's very interesting because it has those 2 little balls together, so it's cute. So you have to that's how you're going to remember a gram stain, because you know what characteristics you're looking for, which is interesting. There's an NAAT non-culture test, but this is probably like a screening. So your gold standard is the gram stain, looking for that diplococci. Remember that, gram stain is your gold standard for gonorrhea. Okay. So the next thing you're gonna look for is complications. Your complications for the woman and the man, and the fetus effects, so a woman who has a baby. So we're going to talk about the complications for just the normal individual. So men, they have sterility for orchitis or epididymitis. So they may be sterile from gonorrhea, which sucks because, you want to feel like a man. They may feel like they lost their manliness to not have sperm. You know what I mean? So there may be a urethral stricture. Why? Because you want to think of urethritis, inflammation, and urethral stricture, same concept. So that's where that comes from. And prostatitis. So prostatitis is the inflammation of the prostate. So basically just think of men, your inflammation is going. All right. So for women, the biggest mainest problems, this will cause women's fertility problems, because pelvic inflammatory disease, there's a thing called Bartholin's glands abscess, and remember this, ectopic pregnancy causes infertility. So you're thinking of pregnancy in your fallopian tube. This is just dangerous stuff. Pelvic inflammatory disease, not fun. Ectopic pregnancy, infertility. These are the complications. You want to nip this out of the butt if you can avoid these complications. So when you're asymptomatic, sometimes the complications can just arise out in the middle of nowhere. So be a monitor of that. So fetus effects are preterm birth, but the main thing to monitor for is blindness. Infants that are given, when they're born, this is standard precaution across the board. They're always given erythromycin 0.5% ointment to the conjunctiva, as we learned in class. And this ointment prevents blindness, or there's a silver nitrate aqueous solution. So I've only seen in the hospital erythromycin as the history of what they do, at least where I live, so that makes sense. And the interventions that you would do for gonorrhea is you want to, before cultures, the doctor may prescribe cephalosporin. But the main thing to remember is there's always a hierarchy of what they choose to give for antibiotics, because this is all the STIs you're going to give for bacterial antibiotics. So ceftriaxone, Rocephin, ceftriaxone is also known as Rocephin, your trade name, but I go by ceftriaxone, and 250 milligram, this is a one-shot dose, IM once, plus azithromycin 1 gram PO 1 dose. So you're just ceftriaxone plus azithromycin. Ceftriaxone is IM, azithromycin is PO. Just remember that is the first intervention that they would choose to give. The reason they're giving both of these is because with gonorrhea, you're going to treat chlamydia also. With chlamydia, you may only treat chlamydia and not gonorrhea. So just be mindful of that. All right, so other notes would be have to treat both gonorrhea and chlamydia, which I said. All right, so remember to teach them no alcohol or sexual intercourse during treatment because of this bacterial. They always suggest you not to have alcohol, usually with antibiotics, but also the sexual intercourse, avoid until after treatment. If you have to make sure if it's gone during treatment, and all sexual contacts need to be evaluated and treated. So remember, the only one that is not going to have to be evaluated and treated after while they're is the bacterial vaginosis, actually. So everything we're going to be talking about is going to have to treat the partners, other than that. All right. So the next thing I want to talk about is chlamydia, because it's very, very closely related. All right, so causes. So the causes of chlamydia is a bacteria called Chlamydia tracheomatitis. So Chlamydia tracheomatitis. Okay. So it frequently co-infects with gonorrhea, as I explained earlier. So that's why I wanted to talk about it at the same time. Transmission is your vaginal, anal, and oral sex to a newborn, and also could be vertically transmission to the newborn child. Women are more infected than men, just random statistic to know. And I definitely told you that it's like co-infects with gonorrhea. That's like a main thing to think about. And the risk factors, it's a woman, adolescents, they're more at risk. New multiple sex partners, history of other STIs, cervical ectopy, coexisting STIs. Just think about those things as risk factors. Some interesting note before we start talking about what are the clinical manifestations. I want to just make sure that you know it is the most reported STI there is out there, at least according to the textbook. So it is like the most reported. Yeah, just thought that was interesting, honestly. So clinical manifestations you're going to see for a patient with chlamydia is it's actually asymptomatic in 75% women and 25% men. So like women, you don't even see it. But it's kind of interesting that it says it's the most reported and it's more commonly associated with women. So I guess cervix exam or exam sound, I don't know. It's interesting. Remember that the discharge, how I said it was green in gonorrhea? Well, it's clear in chlamydia. So C for clear, chlamydia, the discharge. So it's purulent, clear, exuding. Dysuria, burning on the urination site. So yeah, it would just burn if you had problems down there. Dyspareunia, well, that kind of makes sense. So sexual intercourse would be painful. That makes sense. This is the interesting one that's different than gonorrhea that I've noticed. It says vaginal bleeding between periods. So that's like the random thing that I saw that was like spotting just random bleeding. That's like doesn't associate with the period. So yeah. A sore throat from oral sex, lower abdominal or back pain, and rectal pain, anal sex. So there's pain. But I said dyspareunia, so that makes sense. Also, a cloudy smelling urine. Cloudy smelling urine. So clear. It's clear. Just remember that. Purulent. Okay. So we talked about, so how are we going to test for it? Diagnostics, when we actually go to the doctor, so we know what to see. We see the patient with certain clinical manifestations. Now we want to test what if it is chlamydia. Okay. So C for the culture standard. So G for the gram stain, C for the culture standard. You're going to take a tissue, culture tissue. Culture is the gold standard to check for chlamydia. There's also an NAAT, DFA, and EAI. So the NAAT, the nucleic acid amplification test, the direct fluorescent antibody test, the enzyme immunoassay. This is you're going to have to with the first clean catch of a vagina swab or urethra swab. So just remember that these are other like screenings, but just remember the gold standard. Like just make sure you know the gold standard. That's the main thing. All right, so let's talk about complications if they're not treated and they have it. All right, so the complications are going to be Reiter syndrome. This is very unique to chlamydia. So Reiter syndrome is basically an autoimmune reactive arthritis. It's the infections coming from the urinary tract, the intestines, and the genitals. So urinary tract and intestines, genitals, but intestines like randomly out there, I don't know. So it's the autoimmune reactive arthritis, Reiter syndrome. All right, so the complications with women would be your pelvic inflammatory disease, just like in gonorrhea, and tubal scarring, ectopic pregnancy. So it's pretty much like gonorrhea, so it causes complications with fertility in women. Females infertility, as it says here, and make females 5 times more susceptible to develop HIV. So you're becoming more susceptible if you have chlamydia to HIV, but it's just like, not good. Okay. So the fetal complications that we're going to be looking at is infants may develop pneumonia 1 to 3 months after birth, so they're going to be more increased risk for pneumonia, so like a lower immune system, preterm birth, and ophthalmic pneumotorium, which is the same as gonorrhea, basically, because they're co-infected together. So yeah, just remember that. So the next thing I want to talk about is the interventions. So the interventions for us as nurses and medical physicians, what we're going to want to give is partners. Remember this. Basically, it's with all of them, but partners should be evaluated and tested and treated. So there is special considerations to make about this. So the main thing is hold on, let me see which one's the most preferred. Okay, azithromycin 1 gram PO. Remember I said plus azithromycin in gonorrhea. So chlamydia is the one that you give the azithromycin 1 gram PO. So basically gonorrhea is just trying to treat also this. So azithromycin 1 gram PO, it's just a once thing. But remember these side effects, because that's really important to teach the patient what to monitor for. Photosensitivity, your GI reactions, and it's, And also you're gonna have vaginal candida yeast infections may be associated with this, which is interesting. And it's very costly, so the patient may not want to take this, and you would have to give alternatives. And that's what I'm gonna talk about, the alternative options as well. So males also develop infertility for epididymitis. That's very interesting. Okay, so basically I wanted to also talk about that this medication, the treatment for chlamydia is abstinence for 7 days after both partners are treated. 7 days after. So like they're treated and then they have to be like basically treated again, like they have to wait 7 whole days. That's basically like, if you think about it, it's kind of almost like the mikvah. If anybody who's listening to me knows what that is, but that's besides the point. That's like a whole another 7 days. Okay, so that's why you have to make sure they know like you're treated, but you still have to wait 7 days because they won't know if you don't tell them. All right, so doxycycline. So other alternatives is doxycycline, 100 milligrams twice a day. But with the main thing to note for there, it's also photosensitivity to monitor for. So exposure to sunlight, iron products, dairy, so iron products and dairy, and no antacids, which is interesting. So oxyfloxacin is also another option. 300 milligrams for 7 days cannot be used in pregnancy or children under 17 years of age. And it's expensive, so that's another option. Erythromycin is the choice indicated for pregnant women, though. So that's the main thing I want y'all to remember is women, so they have 500 milligrams PO 4 times a day for 7 days. It will cause GI distress, but 3 weeks after treatment to do a test for cure, because it may not cure the infection, so just remember that. So allow time for the antigen to clear. So you want to wait 3 weeks after to check for erythromycin, just remember. So that's the one you would use for chlamydia if the patient were pregnant. And there's another alternative to use also, but this is not for pregnancy. It's alternative amoxicillin, 500 milligrams 7 times a day, or doxycycline, but we talked about doxycycline. So those are like even doxycycline and ampicillin. They're basically all other alternatives. All right, so that's everything for chlamydia. All right, so the next reportable one we're going to be talking about is syphilis. So the main thing with syphilis is I want to talk about the causes, intervention, diagnosis, clinical causes. So the name doesn't really seem like it matches, but it's called syphilis is caused by the bacteria called Treponema pallidum. Okay. I can't say it, but Treponema pallidum. So this is like a spiral, like yucky bacteria. So all of these I'm talking about are bacteria, just so you know, because it's a separate video if you want to watch after for viruses. So it has an increased risk for CNS involvement with HIV. So increased risk for CNS involvement is what makes it so much different. It's like, because there's a thing I'll talk about later about neurosyphilis, or cardiosyphilis, and all this syphilis. All right, so an incubation period is about 10 to 90 days. So just remember that's about 21 days, and which is different from gonorrhea, which was 3 to 8 days incubation. So this takes longer to incubate, so you don't see the symptoms until like 21 days. So they may be infected and you don't even know it. So short period of antibody produced after infection, but then so antibodies basically short period after the infection happens, the antibodies will increase and then they'll decrease, if that makes sense. So, and then the patient becomes reinfected. So basically they build an antibody, but then they decrease afterwards, so then the patient becomes reinfected and it's a big fat problem, if that makes sense. All right, so that's everything that you need to know, except for just remember the transmission enters through the body and through small breaks in the skin, mucous membranes, entry facilitated by minor abrasions that often occur during sexual intercourse. No indirect, but it's no indirect. It's easily killed by heating, drying, washing. So really it's all about this. It's really a true STI, as all of them I'm going to be talking about. All right, so that's the cause. Clinical manifestations are like really fun because there's like all these different levels to like, you'll see different things and you have to like be able to differentiate between them. All right, so clinical manifestations, remember that I said it was all reportable within a week, except syphilis is the one where primary and secondary stage, which is reportable in 1 day. Now we're gonna talk about the primary and secondary. So primary happens within 3 to 8 weeks. So three weeks, we think about 3 weeks, 21 days. Oh, that's how much it takes to incubate. No, duh. You know, that's what I'm like thinking in my head. So that's when we're going to start seeing the first signs and symptoms, if they have symptoms. Okay, so let's talk about this. So primary, 3 to 8 days. That's about 21 days to the earliest. Okay. So they could be explained as hard, painless nodules on the shaft of the penis. So hard, painless nodules, or it could be, which is also known as chancre, basically. Exudate from the chancre is highly, highly contagious. So this word chancre, you want to think chancre, it's like this hard nodule, painless nodule. It looks ugly. All right, so the painless indurated lesion of the penis, it could be on the penis, it could be on the vulva, it could be on the lips, the mouth, vagina, and rectum. That's a lot of places it could be. So it just really depends on where you were infected. So it occurs 10 to 90 days after inoculation, hence the time it takes to work. So you can also get regional lymphadenopathy. What is this? This is the drainage of microorganisms into the lymph nodes, so they're going to be inflamed. And genital ulcers. All right, so now that's all you have to know for primary. So secondary, we're going to talk about this happens within 1 to 2 years. Okay, so what are you going to see in the patient? Flu-like symptoms. So flu-like symptoms, we're going to talk about malaise, fever, sore throat, headaches, fatigue, arthralgia, headache, generalized endopathy. Okay, so basically the patient feels like they have a flu. Non-itchy cutaneous lesions bilaterally. So what do I mean by that? These cutaneous lesions are symmetric, basically a rash on their trunk, their palms of their hands, and the soles of their feet. So this rash is like, but it's non-itchy. That's what makes it so neat. So if you think like, okay, so like the patient has, they're itchy, then you would be like allergic reaction. But if they're non-itchy, you're like, syphilis? So, you know, being healthcare providers, we could be like, no, you've got to get that checked out. All right, so that's the next thing to know. Another thing for secondary is mucus patches on the mouth, the tongue, or the cervix. It's in the textbook. It looks like this patchy area. It could be on the tongue or the surface. The chancre can actually be on the mouth too. It could be on their tongue, and it's like, so it could be like literally in other places like lips and vulva, you know. Okay, so mucus patch is the non-itchy rash, the flu-like symptoms, weight loss, and alopecia. So alopecia is just like hair loss. That's what it means. So you don't feel good, you have lost appetite, all that stuff. Okay, condylomata lata is moist weeping papules in the anal and genital area. So this is also something that can happen in the condylomata lata. And wart-like growth like growth on the genitals. All right, so throughout life or progestion late state, the Latin is time frame is throughout life or the progression to late stage. So you don't, it's kind of like going into something, like you go onto something and you don't know when it's going to end. So can you imagine, you don't know if it's going to show up or not? That's like really stressful. So that's the concept of latent stage. It stopped, but you don't know if it's going to come back. All right, so there's an absence of signs and symptoms of infections. That's the concept of latent stage, and it's non-infectious after 4 years. So if it's been 4 years, then it's considered non-infectious anymore, but up to that, it's still infectious. All right, so the diagnosis is based on positive specific treponol antibody test together. So it's a treponol antibody test, and normal CSF is what would determine being in the latent stage. So they have an antibody, like it is still in their system. That's how you're gonna know. So it's not based on like signs. All right, so the late stage, you're gonna see for chronic without treatment, possibly fatal. It happens within 3 to 20 years of span after the initial infection. So 3 to 20 years after the initial infection is when this is gonna happen. So it can happen in the big span time. You're gonna see those things called GUMAs. So the first one was like with the initial, it was like a chancre. Now in the end stage, you're gonna see GUMAs. These are they're chronic destructive benign lesions. They affecting any organ of the body, especially it happens to the skin, the bone, the liver, and the mucous membranes. So GUMAs, they're in the textbook, it looks like these kind of like circular things. It almost looks like a ringworm. I don't know how to explain it. All right, so neurosyphilis, cardiovascular syphilis, we'll talk about these different things, and then we can move on. Okay, so hearing loss is could be a sign of the neurosyphilis, general paresthesias, general paresis, personality changes from minor to psychotic, tremors, physical mental deterioration, tabes, paralysis, ataxia, areflexia, paresthesias, that tingling of fingers, the ataxia, like you can't balance so well basically, areflexia, not controlled reflexes, lightning pains, damages to the joints, and disturbed speech. So basically it just affects your nervous system. The spinal fluid can contain organisms, and that would cause major damage to your cerebral spinal fluid, so that's going to affect a lot of problems, and this could lead to death. So also the cardiovascular system, you're going to be looking for aneurysms, heart valve insufficiency, and heart failure and aortitis. So these are inflammation to the aortic valve, which causes the heart valve insufficiencies and the heart failure or aneurysms happen too. So these are the problems that it causes. All right, so how are we going to diagnose this after we see these manifestations and also they have all 4 different stages. So the diagnostics we're going to want to use, we always want to check the sexual history of the patient. There's a thing called FTA-ABS, dark field microscopy. So this is this dark field microscopy tests for the presence of spirochetes, so these spiral things. So you're going to look for the spiral things on the dark field microscope, and direct fluorescent antibody DFA test of lesions, exudate, or tissue that confirm the clinical diagnosis of syphilis. So we can use the FTA, the fluorescent lighting antibody. Microscopy. All right, so that's what we're going to be looking for, is that antibody test. Okay, so the non-specific antibody screenings is the VDRL and the RPR, but these are screenings and they will still need to be further evaluation, because screenings only get you started and then you want to do the next diagnostic to make sure. So VDRL stands for Venereal Disease Research Laboratory, and the RPR stands for Rapid Plasma Range. Just remember that diagnostics and screenings just give you an idea, and diagnostics you have to go to the next level. Okay, so now that we know the diagnostics, let's talk about the complications. So the complications mostly are associated with the later stages. Neurosyphilis is our degeneration of the brain, the locomotor control, and ataxia, not being able to control. Aortic is valve scarring, as we mentioned, with cardiovascular syphilis. Aortic valve insufficiency eventually leads to heart failure. Damage to the bone and liver, as we talked about, the GUMAs. Cardiovascular syphilis can also cause aneurysm, not just aortic valve insufficiency, but which presses on the structures, causing pain and may rupture. So our fetus, we want to monitor, it's infected after the 10th week. It increases the risk of stillbirth, so basically they're born dead, and neonatal death. All women are screened on the first visit for prenatal visits. Just remember that. First visit, all women are screened for syphilis, especially since it can also be asymptomatic. Interventions that the doctor is going to, and the nurse is basically is administer, but they don't prescribe. So what you're going to see them administering though is their first choice is penicillin G, benzathine, or aqueous procaine penicillin G is the first treatment of choice. Okay, let's see. Primary and secondary, and so this works for primary, this works for secondary, and early latent of less than 1 year. So if it's less than 1 year of latent stage, then it can be used. Doxycycline, ceftriaxone, or tetracycline. Ceftriaxone, doxycycline, and tetracycline is only used if penicillin is it definitely contraindicated, but it's often associated to basically what they try to desensitize patients from penicillin if possible, but if it's 100% contraindicated, then that. Also counsel and test for HIV because it often can co-occur, and counsel the patient because it can cause a lot of problems. All contacts for the last 90 days need to be treated for this, for syphilis. All right, so that's everything for syphilis, and the next one is bacterial vaginosis. Okay, so bacterial vaginosis is the cause. They have multiple causes. So the ones I have are Gardnerella vaginalis, Mycoplasma hominis, Prevotella mobilinicus species. Okay, so basically it's a lot of different kinds, but just remember the ones with vaginalis is the ones associated with bacterial vaginosis. All right, so it's not necessarily from sexual activity. It replaces normal lactobacilli species in the vagina for the normal bacterial flora. It's not clear if BV, bacterial vaginosis, is an STI, but it is linked to having multiple sexual partners or a new partner. All right, so our clinical manifestations are a little more unique in nature. So they'll have a thin gray-white vaginal discharge. It's gonna have this fishy odor. So when you think of fishy odor, think of bacterial vaginosis. So thin gray-white vaginal discharge and fishy odor. Men do not experience signs and symptoms as much that women have. All right, so how are we gonna diagnose bacterial vaginosis? The gold standard is a saline wet mount, and they need 3 out of the 4 diagnostics to be considered positive for bacterial vaginosis. So do they have the homogeneous thin white discharge, or thin gray white, I guess, presence of clue cells, vaginal pH of more than 4.5, because it's supposed to be acidic down there, so it's, and a fishy odor with or without CoH with test, which is supposed to diagnose for that fishy odor that they look for. All right, so the next thing I'm gonna say is also during complications during pregnancy and is associated with pregnancy mostly. So the preterm labor and birth, postpartum endometritis, so inflammation, chromiomyositis, and post C-section, there could be a wound infection because it's basically auto-inoculation. There's fetus complications, there's possibility of pre-birth term and low birth weight. Tracheomoniasis really is very similar. The only difference is that I'm going to focus on is what you're going to see. So it's gray, yellow, green, frothy. So remember tracheomosis for trachea, look at the CH and think cakey a little bit, you know? So gray, yellow, green, frothy, discharge, vaginal itching, pain, difficult urinating. Male men can also have this, painful urination, slight discharge. It's more associated with women though. So also, this is very associated more associated with sexual intercourse. So tracheomoniasis really has very similar interventions to bacterial vaginosis. So I think of them kind of combined together as how I understand them. It's just what you're going to see and how you're going to diagnose it is a little bit different. Like gray, yellow, green, frothy is a little bit different than thin, because thin and frothy are like opposites, and gray, white versus gray, yellow, so a little different tint. All right, so our interventions are going to be, the partner doesn't need treatment is the difference, and metronidazole is the treatment of choice, but it's contraindicated in the first trimester. So they give 500 milligrams twice a day, or 250 milligrams 3 times a day for 7 days, so it's just 2 different options. No alcohol can be given at all whatsoever to these patients because there will be an alcohol reaction. It's like a sulfa reaction. There'll be less appetite with metronidazole, and as well as a metallic taste in their mouth, so make sure the patient knows, teach that. If that's not given, clindamycin is the second choice, which is like 300 milligrams PO 2 times a day for 7 days. But metronidazole is the one that we think about, Flagyl. Metronidazole, same thing as Flagyl for bacterial vaginosis. That is everything that is about bacterial STIs. And just remember, your portable ones are syphilis, gonorrhea, chlamydia for 1 week, and primary and secondary stages for syphilis are in 1 day. So that's everything, and good luck and happy studying.